Good afternoon, friends. We have started about insomnia, treatment of insomnia. We have categorized it. We have seen various uh, ways how to treat it for various type of insomnias, and we have seen that the important treatment where one was cognitive behavioral therapy, that is CBT, and pharmacological treatment. So these two treatment we have seen. After that, we have seen what are various cognitive behavioral therapies for insomnia, and we have gone through various kind of these studies, these what we can say therapies. Then we are going for various drugs which are used, which can be used, and what are options are available. So we have got, you have studied it from pharmacology. We have got various drugs which are acting through GABA mediated actions. Some of these are acting on benzodiazepine receptors. Some are acting on other places where they are acting. So we classify them as a benzodiazepine receptor agonistic modulators. Again, structurally, and they are which are not modulating benzodiazepine receptor or not acting through GABA receptor directly, indirectly, like that. So let us see these drugs accordingly. First of these are non-benzodiazepine, although acting on benzodiazepine receptor, but structurally, chemically, they are not benzodiazepines. Example of these are cyclopyrrolones, that is S-zopiclone. S-zopiclone is S-enantiomer of zopiclone. So zopiclone and they are same. Some of people call them as a Z type of drug. Z means zopiclone, zolpidem. These are all starting with Z. We call them as a Z class of drug because they are neither barbiturates nor benzodiazepines structurally. So these are the tablets are available as 1 to 3 milligram tablets. Recommended doses around 2 milligram. Then it is primarily used for sleep onset and maintenance of insomnia. These drugs are intermediate acting, and there is no short-term usage restriction is there in this case. Actually, I was expecting, I asked you about, no, I asked for earlier one, next one, that is about what I say, panic disorders and this, that details I have not yet received. Panic disorder. I think you have made this table of pharmacokinetics during sleep one. Yes, many of you have made it. So from that you can understand what is the duration of action, and accordingly we can plan how much dosing is needed. Then next is this imidazopyridines. Example of this is zolpidem. Zolpidem can be available as a normal plain tablets or control release tablet. It has got maximum dose can be given is 10 milligram. Then 5 milligram it can be okay for elderly, debilitated or hepatic impairment. Those if it is given as a control release, then 12.5 milligram it can be given. And in case of elderly we can give it 6.25. It is used for the sleep onset insomnia, that is where the sleep is the onset of sleep is a problem. We have categorized all these different kind of insomnias. So zolpidem is and zopiclone both are very good for sleep onset and maintenance insomnia. It is short to intermediate acting drug. It is both are primarily used for sleep onset and maintenance insomnia. So all these are Z type of drug which are very good for sleep onset and maintenance insomnia. That is what if you remember, you can revise it, you can go through it. That is, person is going to bed but lying on the bed and cannot sleep. So that sleep is not onset. Maybe feeling sleepy but cannot sleep. So that is the onset is not proper, and maintenance means after sleep it is not reaching to the proper depth, it is not reaching to the deep sleep, and there are awakenings in between. So in both cases it is used. Then next is Zaleplon. So this is third Z drug. So these are three Z drugs we have seen. That is what zopiclone, zolpidem, and zaleplon. These all three are we call them as a Z class of drug. It is pyrazole pyrimidine, and the dose is 5 to 10 milligram capsule. It is used for the sleep onset insomnia, maintenance of insomnia as long as 4 hours is available for further sleep, and it is short acting. So in both cases it is very good. Then benzodiazepines. Nowadays other benzodiazepines which were earlier prominently used are comparatively less used. The benzodiazepine which are frequently or they are more preferred when they are like estazolam. It is 1 to 2 milligram tablet. It is short to intermediate action. Then temazepam is 7.5, 15, 30 milligram capsules are available. So dose can be anything between 15 to 20, 30 milligram in the normal people, and 7.5 in the elderly or debilitated people. It is also short to intermediate action. Triazolam is 0.125 or 0.25 milligram tablets. Then this is short acting one, and the duration of action is less in that. I'm not speaking about this onset or duration of sleep, but it is duration of action of the drug, that is triazolam. Then next is a flurazepam. It is 15-30 milligram dose range is there, and we have seen that in all cases we are using minimum possible dose in the elderly or which are debilitated. Flurazepam is long acting, but it is causing risk of residual daytime drowsiness because it is the half-life is very high. Then next is melatonin receptor agonist. They are not scheduled drugs. Scheduled drugs means scheduled drugs where the prescription control is there. It has to be very rigorously maintained because this can be either used for any other purpose also, or it can cause problems of adverse effects and all if the doses are more. So in that cases these are not there. It is non-scheduled drug. Rameltion is melatonin receptor agonist. And 8 mg tablet is given, primarily used for sleep onset insomnia, short acting type of drug. So these are various drugs which are available. Now for this, most of these when we are taking, we call it as a omnisora. Omnisora means before bed, before going to bed, because we do not want any daytime sleep. So before person goes for sleep, these drugs are to be given. What are the general problems or general comments about sedative hypnotics? These are having various benzodiazepines are having their own problems. Example of this, they are having disruptive sleep related to behavior, that is including sleepwalking, eating, driving, and sexual behavior. That is, in sleep people will have walking in sleep, may feel this what we can say, may feel hungry, like that. So these are associated. Patients should be cautioned about the potential for these adverse effects and about the importance of allowing appropriate sleep time, using only prescribed doses and no overdoses. Avoid all these overdoses. Do not have any combination of benzodiazepine receptor hypnotics with alcohol, other sedative, or sleep restriction. So when already sleep restriction cycles are going, in that cases it should not be used. Other comments are there. Administration on empty stomach is advised to maximize effectiveness. So give it before evening meals, wait for some time, then go for meals, take the drug, and then one can go for sleep. Not recommended during pregnancy or nursing, because we have seen that they can cause effects, and particularly respiratory depression in fetus can be dangerous one. Caution is advised if the signs symptoms of depression then compromise the respiratory function like asthma, COPD, sleep apnea are there, or hepatic or heart failure are present. Caution and downward dosage adjustment is advised in the elderly because of changes in their body fluid and their efficacy. Then safety effectiveness in the patient less than 18 years is not established with these drugs, and therefore in that they should be used with caution. Care has to be taken, they should be observed, and then it should be given. Additive effects on the psychometric performance with the concomitant CNS depressant and use of alcohol, if it is there, then they will cause additive effect, and it can cause psychotomimetic effect, we can say. As rapid dose decrease or abrupt discontinuation of this can produce withdrawal symptoms. This is really a problem in most of these drugs which are acting on CNS. So whenever there is a withdrawal, it has to be, we call it as a tapering of doses, and this tapering should be done accordingly. I think we have seen tapering of doses, I can recall this. No, we have seen in earlier case. So there should be tapering of doses. Slowly the doses has to be tapered, and the accordingly this treatment will be given. If we gradually reduction in the dose, that is what we call it as a tapering of doses. Then yes, certain antidepressant like amitriptyline, doxepin, mirtazapine, paroxetine, trazodone are employed in the lower doses than the normal treatment, because again they are getting accumulated during this, and therefore they should be used with the comparatively lower doses. These medications are not FDA approved for insomnia, and their efficacy for this indication is not well established. Fortunately, in India we don't have OTC medication for sleep, that is which are containing antihistaminics as a primary agents, because it is their adverse effect we are using as a effect. What is adverse effect? Because they are drowsiness. Efficacy for the treatment of insomnia is not well established, and therefore it cannot be used for long term use. So basically we are having majority of drugs, they are the agents which are acting through benzodiazepine or melatonin receptor. They are the rather only treatment. If they are not at all successful, and despite changes in benzodiazepine receptor agonist, then as a last resort we are going for the treatment with this antipsychiatric drug or other drowsiness drug or other CNS depressant. So here we finish the important topic, that is drugs acting or drugs in the treatment of insomnia. Okay. Now next treatment we can have, or next type of drugs which are there, which we call it them as a for anxiety. Now this we should be knowing what anxiety is. I think I'll change it. Okay. Now what anxiety is? Anybody? What is anxiety?
A feeling of nervousness.
Feeling of nervousness. Okay. Any other thing? Any other?
Like feeling anxious about something
Yes.
or fear of something.
Yes, sort of fear about something. Okay, or particularly feeling insecure about what can be the next outcome, sort of what will be the future related thing. The anxiety as such everybody may have, but when it crosses, when it becomes too much, then that results, or that then we can call that it is a problematic one. Just a minute late. हेलो बोला हाँ 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 ठीक है सर ओके So this is what anxiety is, that the person is feeling as she told, anxious or worried, and not clear. And because of that, what is the problem? Because I told you, anxiety is that way, it should not be a problem. Everybody is anxiety, everybody is anxious about things. Now sessionals are declared, many of you might have anxious. What will be there, what will be syllabus, what will be the type of question paper, what type of questions. So it goes on. But then when it reaches beyond certain limit, then that anxiety causes the destruction. How it causes destruction? Because as anxiety itself is a what? That is an increase in the thought process. Most of the thing in that is, these thoughts are too much. Too much thinking is there. We have already seen in various psychiatric diseases that a person goes for too much thinking. We have seen in schizophrenia, we have seen in depression, that the thinking process changes, and because of that, this thinking process is not normal, and because of that, too much this neurological activities or psychiatric activity, we can say. Psychiatric means mind related, thinking related. So because of this mind related activities, one cannot focus on the things. Those example I can tell you, people who are those get anxious about examinations. Actually many times it goes as a cycle. That is, what happens is, initially they cannot concentrate well, then because they cannot concentrate well, as soon as any event is declared, they become anxious about it. Once they become anxious about it, they go for thinking about it. More and more thinking goes on for that. Suppose anybody is thinking about any event, what can be there? So up to certain level, that thinking is giving you, or it is, we can say, it is taking you towards the path of solution. But thinking beyond that particular level, okay, up to that thinking or up to that worry is there. Okay, what about my examination, how it will be? If I am thinking, then I plan something, I try to study on that matter. Then I have got, yes, that anxiety, that worries has led me for some solution of it. But when that goes on increasing, then पेपर कैसा आएगा, सर क्या क्वेश्चन पूछेंगे, मैंने तो ये पढ़ा नहीं, इस टॉपिक पे क्या आएगा, उस पे क्या आएगा, फिर ऐसा तो नहीं पूछेंगे, वैसा तो नहीं पूछेंगे, फिर कैसा रहेगा मार्किंग. Now too much thinking in that way, it goes what? It obstructs the normal thinking or normal cognition process, or normal learning process is affected, because every learning may anxiety becomes obstruction. Because of that, learning will not be proper one. If learning is not proper, then again inbuilt feeling will go that, yes, I am not able to reproduce. That will cause sort of fear. Many times this anxiety is having deep rooted fear in there. So fear emotion is particularly for each and everything. So I told you, fear is that way physiological. That is, fear is giving some input, and that can be that can be converted into some output which is a positive one. That can give you confidence also, that if this is a problem, what this is a fear, this is a problem, for that what can be solution. That thinking process itself can sort of anxiety, because it is a future one which is not actually immediate situation, but the situation which is after some time, which may or may not occur. कोरोना हो जाएगा तो, मुझे हो जाएगा तो, मेरी किसी को हो जाएगा तो, this is what kind of fear is there. So up to certain extent fear is good. That fear will be used for the caretaking. That will be utilized for the, it will be the base serving for the taking precautions. Be vigilant. But if the person becomes too much, then may not able to concentrate on day-to-day work, may not able to have cognitive function, may not able to have any other mind related or brain related functions, and it can cause decrease in the output. and this decrease in the output will reflected in decrease in the performance and other problems. Other problem we have seen that anxiety can become a root cause for the sleep disorders. Anxiety can also affect the person's psychiatric situation, means it can also one of the important what we can say contributor in the or important risk factor in the psychiatric diseases or affective diseases rather we can say. So there are various kind of anxiety diseases. We can categorize them: generalized anxiety disorders, then obsessive compulsive disorders, we call them as OCDs, panic disorders, then phobias, and post traumatic stress disorder. These are the most prominent four are there. There can be even many, but yes, most important four are these: that is generalized anxiety disorder, then OCDs, that is obsessive compulsive disorders, panic disorders, phobias, and post traumatic stress disorder. Now, generalized anxiety disorder, that means the person is always having anxiety or one or other issues. Okay, he doesn't need, he or she doesn't need very big thing to worry about. So, for any matter, the person can go into worries. Okay, so this is called as a generalized anxiety disorder. Obsessive compulsive disorder, that is OCDs are there. They are very typical, they are very peculiar. Example, if somebody is fearing about now take example of corona. Government has warned that you should wash your hand or you should have sanitizers and mask, etc. So these are the guidelines. Now as soon as the fear goes in the mind of the person that corona is there and these are the preventive measures, then the person may go for washing hand. Normally how many times you people wash hand? What can be the routine? What should be the routine approximately? If you touch something, if you have gone somewhere out or you suspect that this might have contaminated your hand, then you can go for it. Okay, but then if the person gets OCD, then can wash hand maybe even more than 50 times or 100 times. Even will not be sure about it whether the person wash hand or even be suspicious on himself or herself that whatsoever hands washed earlier were not proper or accordingly may go for washing again and again. So these type of things are called as a obsessive compulsive disorder. They are obsessed with that. They compulsorily go for that particular thing, and this is what called as a obsessive compulsive. We shall see again. Panic, they are occurring particularly in certain situations when somebody has failed that some signs are matching, temperature is there, some signs are matching, and then gets all of a sudden worried that अरे बाप रे मुझे COVID हो गया, and then get worried about it because some signs are matched. Okay, generalize and panic, what is the difference? Generalize, even in all condition he will be thinking whether there are signs symptoms or not. In all cases he is worried, he is always anxious. But in panic cases it is not like that. Panic cases means when the event is occurring, at that time all of a sudden the person start having these signs. So all of a sudden sweating starts, palpitation starts, then the normal thinking process goes off, and try to escape, try to run away from the situation, and that is really a difficult situation. I think particularly it is very common with the students who think about one night study, and then all of a sudden when they find that when they see the question paper, then they face this music, they find that they cannot solve it, and then it starts sweating, it starts palpitations, the sweat in the palm, and fail ho jaunga, then this kind of very end feelings are there. And this panic disorder can in many people it can result into many difficult consequences. Immediately this can get into converted into depression like thing, or affective diseases like situation, and can becomes very depressed one, even can lead to suicidal attempts. So this is how panic disorders are difficult, they are dangerous one. But they are not always, they are particularly when that situation arises. But they are prone for that situation because their this neurotransmitter release is comparatively not as per the normal person. Phobias are again fearful. This one, there are many phobias one can have. That is particularly of one or other thing, phobia one can have. So it is a fear of a particular thing, and particularly these fears are beyond what we can say normal situations. So if somebody feels that because of something is happening, then we'll develop phobia against this. So there are many phobias are there. And next is post-traumatic stress disorders, PTSD. These are what particularly again sort of feeling of what we can say depressed too much or affective type of symptoms, but these are post-traumatic. Post-traumatic means examples are there when in India we have got various earthquakes like which were very big one in magnitude. Example in Maharashtra we had a Killari, most probably birth of many of you, and there was one in Gujarat in around 2000 somewhere. So these were very terrific when people have seen or their accidents are taking place. So many times people have seen that their relatives, they are getting buried under all these building collapses. So this is a psychological trauma these people have got. So because of this trauma, because of this severe shocking conditions, the stress was developed, and this is called as a post-traumatic stress disorder. So we can have trauma two types, physical and mental trauma. Physical means because there is an accident and something falls in that in their head, and that is a trauma is one thing. And second is a mental trauma because of the severe shock. They lose their near dear one, or there is a big financial loss. There is a loss of service. There are many such things which are undesirable thing. Unexpectedly undesirable thing occurs all of a sudden, for which they are not mentally ready, or they cannot become they cannot face that situation. Then we call it as a post-traumatic stress disorder. So these are various situations, various anxiety conditions that are causing various problems. Most common problem or most initial problem is because of that they will not allow person to sleep properly, because even the person goes into sleep, he will be having that kind of worries. May it be about related to job, may it be about whatsoever kind it may be. So they just need that simple issue. They need just point to worry for. So even they can worry for anything on earth which can be there, because their mind is like that, and therefore these worries will be there. They will go on thinking. And biggest problem with that is their worries do not bring, I remember a very good quote, that worries do not bring solutions, worries rather affect solutions. Worries can be only up to certain extent, as I told you, it can be just as an input, but that input should be smartly and fast, rapidly converted into an output. It should be a positive thinking process that this is a problem and I have to solve. But if that goes in anxiety mode, then it is just thinking about problem. There is no thinking, there is no idea about solution, and therefore continuously thinking only about problems and the outcome of the problem without any role of the solution. That can result into not reaching to solution, and then what happens is, for what the fear was, that comes into this one. And because of the example, somebody is having fear about examination, अरे यार सेशनल डिक्लेयर हो गई अभी नेक्स्ट महीने में. Now worry has started. Those who are wise, they will start reading, they will start going through it. Others will go, क्या होगा, क्वेश्चन कैसे होंगे, पैटर्न कैसा होगा, ये कैसा होगा, वो कैसा होगा. In all these, most of the energy may get wasted, and then all of a sudden they will find that they have not had enough preparations. Then this generalized anxiety can go into panic. It can go into panic, and this panic can result into problem into this can go into problem, that is no solution is possible. Even if during that worries, during that anxiety, if they are trying to study, they will not able to concentrate properly, and this will affect too much in these people. So most of time their treatment will be common. How to diagnose and how to make it, we have seen various scales, just like we have seen various depression scales. So I think before this we have discussed about various scales which are able to make it or which are able to give us the guidance about various anxiety disorders. So along with schizophrenia, we have seen various scales. Similar, these scales are used, the questionnaires are used, and they give, the output indicates that the person remains worries. Example, if somebody asks how many times you wash hands a day, do you have any fear about it? Okay, so suppose I say that I have fear that if my hands are not cleanly washed, and if I have touched any place where my hands can get contaminated for coronaviruses, I should wash my hands or I should apply sanitizer. That is fine, it is correct, appropriate thinking. But if my answers goes that I worries and I am not very sure, I am not very confirm about whatsoever I have done it a few minutes before, whether it is effective or not, or even I do not able to recall whether I have done it, then I'll do it, and you will find that people have done it so many times. Those who are having OCDs will wash it or will sanitize their hands so much so that almost their hands become, whatsoever protective oil layers are there, they gets removed. Okay, and they becomes dry, rough, and the skin can be easily damaged in these people. So there are many. This is just simple. Suppose somebody says this should be done, and then it goes into their mind. These activities can be repeated for a long time. We shall see about OCD one more information about it when we will go for OCD. So these things are there. This has to be checked. This has to be confirmed. Let us see what are the general treatment principles. As I told you, all are similar. So benzodiazepines are indicated for the short-term relief for 2 to 4 weeks only of the anxiety which is severe, which is disabling or causing the patient unacceptable distress, occurring alone or which is occurring in association with insomnia or short-term psychosomatic organic psychotic illnesses. So this indicates that these are the consequences of anxiety disorders. Psychosomatic, organic, psychotic illnesses or insomnias. They are the further consequences. Apart from that, it causes distress and it causes difficulty in finding actual solution. Because when the person is worrying, is not trying on the solutions. When the person is thinking properly, without worrying, then can find a good solution. The use of benzodiazepine to treat short-term mild anxiety is inappropriate. If it is mild anxiety and if it is for short-term, it can be done with cognitive behavioral therapy only. Patient taking benzodiazepine may report paradoxical increase in the hostility and aggression. Paradoxical means we know that it is a CNS depressant. It should cause calmness, but it causes hostility and it causes increase in the hostility and it causes aggression. So it is, we call it as a paradox. our belief, our knowledge, our basis says that it should cause CNS depression, but it causes opposite to it. So we call it as a paradoxical. Adjustment of the dose usually attenuate these impulses. So we can either increase or the decrease. We can do anything about it. The effect range from talkativeness and excitement to anxiety, perceptual disorders, and aggressive and antisocial behaviors can occur with this benzodiazepine treatment. Anxiolytic treatment should be limited to the lowest possible dose and for the shortest possible time. There is no need to go on for highest duration and highest dosage. The NICE guideline recommends that benzodiazepine should not be used to treat panic disorders and should be used with care in the post-traumatic stress disorders. So this is very important. They are no use. Their use should be restricted only for OCDs and generalized anxiety, or GADs we call them. Other treatment methods should be commenced as soon as possible depending on the diagnosis and underlying causes. So what other method, as I told you, cognitive behavioral treatment, in that relaxation, psychotherapy treatment with antidepressants we can go for. Long-term use of any compound to deal with mild anxiety is generally not advised. As I told you, when mild anxiety is there, non-pharmacological or treatment using this cognitive behavioral therapy is the best. Consequences of long-term use are liable to outweigh the benefits. If you remember, we have seen these problems in all the psychiatric diseases and including insomnia, that there is a development of a habit, dependence sort of is developed, and if the dose is abruptly stopped, then it causes a big problem. It can causes more severe condition in some cases. So if we do not use treatment in mild cases, this is good thing, and we can go for various things. So drugs will be available when there is an emergency. Long-term use of any compound to deal is not advised. As I told you, consequences are having more losses comparatively. The benefits are comparatively less. Decision for longer term treatment must be considered on an individual basis, and only when the benefits of doing this long term treatment, they are beneficial, they are more beneficial than the risk. Then a repeat prescription should be avoided in these, particularly with the major personality problems. We call this as a personality disorders, anxiety disorders, etc. OCDs are personality disorders. In schizophrenia, depression are the psychiatric diseases or affective disorder, personality disorders, sleep disorders. So we categorize them into different ones. So this is a personality disorder, and whose difficulty are unlike to because if we are using this, the difficulties are not resolved. Benzodiazepines should be avoided in those having a history of substance misuse, in that it should not be used. So what are the drugs which are available as anxiolytic agents? First line drugs are various SSRIs. You have studied all these. You may have a revision for this purpose if you wish from pharmacology. Already we have studied most of the drug in various conditions. Example, we have seen drugs like SSRIs, citalopram and its S analog, that is S-citalopram, fluoxetine, fluoxamine, paroxetine, sertraline. These are all first line treatments. Then those which are having restricted use, or those which are not of first line treatment, example of these are clomipramine, imipramine, lofepramine, venlafaxine, muclovimate, mirtazapine, propranolol, adroxine, buspirone, benzodiazepine, diazepam, lorazepam, oxazepam, and pregabalin. Pregabalin is a GABA analog, and it has been indicated, it has been advised in many conditions including pain. I think when we will go for pain topic, then we shall go for again this, but particularly we call it as a neuropathic pain. In that very few drugs are available, but this is a new drug, it is quite costly, and this can cause good drowsiness because it is a sort of GABA agonist. So this is a pregabalin. For secondary care initiation, we can have clonazepam, uh, which is actually licensed for epilepsy. It can be used, we call it as off-label use, because label use is epilepsy, but we can use it in that conditions. Then chlordiazepoxide, we can, if the treatment is not successful, so far we have seen only one drug has to be given, but if it is not useful, then we can go for augmentation with atypical antipsychotics, or we can add valproate. Then the drug like duloxetine can be used, which is a newer one, which is non-pharmacological agents. So these are various anxiolytic agents which can be used in various conditions. So which antidepressant can be used in what condition, that we can check. Okay, we have got different kind of conditions. We have seen GADs, that is general anxiety disorders. Then second are panic disorders. Third are OCDs, that is obsession and compulsive disorders, social phobias, and post-traumatic disorders, stress-related disorders. So citalopram is useful, or it is good only in panic disorder and has no importance or no big role in other four. I'm sorry. Clomipramine is good for OCD and social phobias. Escitalopram, that is the analog of, this is really interesting, that is citalopram is useful only in panic disorder and not in other condition, while escitalopram, its S analog, is effective in variety of condition except post-traumatic. It is useful in most of the condition. Then fluoxetine is useful for OCD, fluoxamine is OCD. Then paroxetine is for OCD, moclobemide is for social phobias. Paroxetine also is a similar thing, that is for GADs, social phobias, and post-traumatic social disorder, stress disorders. Sertraline also, except generalized anxiety disorder, it can be useful in many conditions. Then duloxetine is useful only in GADs. Venlafaxine is not clear, but we can give this extended release, and it can be useful in immediate release is not very useful. It takes time for that, but extended release will cause, it will be effective in generalized anxiety disorders. It can be useful in the panic disorders, and it can be useful in the social phobias. So these are various agents which can be used or which are effective in various conditions. SSRI can worsen the anxiety at the start of treatment initially. So it is advisable to start at a low dose to minimize this and titrate slowly upwards. A short course of benzodiazepine like diazepam may be helpful during this period if the anxiety is troublesome. So initially SSRIs can worsen the anxiety, and therefore one should go for either starting along with diazepam and slowly reducing the diazepam or benzodiazepine and increasing the dose. So this is how we can use. Already we have seen this, that is what kind of drug we are going to use. We are going to use SSRIs for the first line treatment. If it is ineffective, then we can go for alternative SSRIs, or we can go for venlafaxines. Then there are increased likelihood of patients stopping treatment because of the side effects, withdrawal symptom, and toxicity in overdose. So in that, whatsoever antidepressant guidelines we have seen, accordingly we can go for. Venlafaxine we are using as a remote resource when the first line treatment are not helping, because if you remember, we have seen venlafaxine as a second line treatment. So when first line treatment with this escitalopram, fluoxetine, fluoxamine, paroxetine, sertraline is not working, then we are going for that. So we should remember this, that yes, we are going for it, venlafaxine, only when the first line treatments are not working. Pregabalin only can be used when two SSR venlafaxine are not tolerated, then, or they are not effective, then pregabalin we can give. Use twice a daily dosing instead of 3 times a day. Advise patient treatment periods up to 12 weeks and needed to assess efficacy. Review the effectiveness and side effects, and if everything is good, then continue it for that, and review the treatment every 3 months and thereafter. Beyond this, the individualized approach should be adopted depending on the needs of the preference of the patients. Other treatments, just other we can have augmentations. Let us see which augmentation we can do with weight. So see, these are the augmentations. See, these are not the treatment. Suppose what's your first line treatment we are giving and we are not getting, we are going for second line treatment also, and we are not happy with the progress, the prognosis is not correct, then we can add one more drug into it and we'll call it as a augmentation. We have seen this augmentation earlier. So what we are doing, what augmentation we are doing, we can add antipsychotic, a typical type of antipsychotic into it. This area of research into this atypical antipsychotic augmentation is going on. Generally, there is a less risk of extrapyramidal symptoms than the older agents. They were previously widely used in the generalized anxiety disorder. So all this haloperidol, chlorpromazine, they were used earlier, but the newer can also be used, and fortunately they have less extrapyramidal symptoms. But proof wise, if we will go on evidence wise, we have seen that is class of recommendation. If you remember earlier, we have seen that, and it shows how many clinical trials are conducted, what kind of design it was there, and on the basis we have given the rating 1, 2, 3, 4 like that. So there is a very limited evidence that shows that they are beneficial. Olanzapine, risperidone and ziprasidone, they are effective. High side effect there with some of these agents like hyperglycemia, diabetes, other example of olanzapine, and they are not actually licensed for generalized anxiety disorder, and therefore we call it as a off-label use. They are having off-label use. Beta blocker, they are used for somatic symptoms like tachycardia, sweating, tremor. Propranolol is used for this. It is licensed for that, and it is having limited role. Particularly, it assists for the parallel symptoms which are there, or which are the outcome of the anxiety, as we have seen sweating, tremor, etc. So their licensed dose roles may be too high for some patients and lead to cardiac symptoms, because we have to give more dose so that the blood-brain barrier crossing is there, but peripheral effect can be more and it can be a problem one. Potential for interaction with other drugs and cardiac symptoms, it should be avoided in asthma because beta 2 related effects, hypotension and hypoglycemia. Then next is buspirone. It is considered to be effective as benzodiazepine. It has got a better side effect profile. It is licensed for anxiety disorders, but proofs are not sufficient. Although it has been found to be more effective than placebo, but still the comparison is not clear. Nausea, dizziness may also be there, particularly it occurs after dizziness, after discontinuation of the treatment. There is a delayed onset of action. It required 4 weeks to show the action. That is the problem. Then hydroxyzine, it is licensed for this, that is anxiety disorders, but again we can say that class of recommendation goes to be like that, where evidence is not clear, the sufficient clinical trials are not there, but though it shows more effective than placebo, but we don't have enough data available for its actual activity. It can be more sedating than other agents which are available. Then moclobemides, that is what? MAO inhibitor. It is not licensed for GAD. Evidence base is very small for many other antidepressants, and therefore it cannot be there. In whatsoever clinical trials it was checked, it was found to be as effective as fluoxetine and clomipramine, and accordingly it should be there. So here we finish most of the treatment related to generalized anxiety disorders. Okay, we can just go through further details, what are they, and accordingly we'll go for additional other data which are related to anxiety disorders, various anxiety disorders. So in the meanwhile, please go through the pharmacology if you have studied it, and make the note as you have done earlier during insomnia. What are various? You can also have this assignment for how to distinguish between various kind of these diseases. Okay, what are various diagnostic tests, as we have seen earlier about diagnostic tests. So this is, you take this as an assignment, how to have differentiation between generalized anxiety, panic, OCDs, and post-traumatic diseases. So please go through this, make a chart table like situation and various drugs which are used for that, so that you will be prepared for the next topics. And if you have any difficulties, definitely you can put whenever you can. Okay. For sessional, whatsoever topic will complete before sessional, that all will come put it, because syllabus is very less covered. We'll try to reach towards 30%. So whatsoever happens up to that, we'll have everything into it. So I hope it's clear. Take care and be careful.